the atmosphere, the wet atmosphere, I can
Taste of
It's like getting the band back together, seeing you guys. Thanks for coming. I'm more casual than usual because in 6 hours I'm on my way to Portugal. Sucks being you all. 8 days of good times. My exam questions are in. We're going to cover it. It's beautiful, okay? So let's do that. We're going to talk about drugs that prevent coagulation or blood clot formation. We're going to talk about so-called clot busters, drugs that dissolve clots rather than prevent. And we're going to talk about drugs that inhibit platelets from aggregating. And then finally, we're going to do just the opposite. We're going to talk about drugs that promote coagulation in bleeding disorders. So those are the 4 major things I want to cover today. And I reviewed what everybody else is doing, so I know it's coming hard and fast. So I'm going to reiterate some of the things you've already may have heard today or yesterday, but from a pharmacological perspective. Remember, I'm not reinventing the coagulation cascade, but I do want to bring to your attention in the coagulation cascade, what is targeted by drugs? Remember, that's my interest for y'all. So pictures, of course, worth 1,000 words. And this is a scanning electron micrograph of a blood clot. And it illustrates the important things we're going to intervene in today. So these cool purple things are platelets. And of course, others have described more eloquently than I did today or yesterday that one of the initial steps in stopping blood loss or hemostasis is aggregation of platelets forming a plug in the vascular wall. That's shown here, followed by the conversion of fibrinogen to fiber, which is then insoluble, and it forms these really cool spider web-like thing. And this fibrin clot, if you will, strengthens and reinforces the platelet plug, ultimately regulating hemostasis. And these other things are just trapped red blood cells. So anyways, to remind you, hemostasis is stopping blood loss at site of injury, and it starts with platelet aggregation followed by a fibrin clot. Recall, we have both naturally occurring or endogenous anticoagulant and procoagulant systems in our bloodstream to maintain fluidity when fluidity is necessary. And clot formation, when clot formation is necessary, it's a delicate balance, right? And any perturbation of that balance can lead to pathological clot formation, thrombi formation, causing a variety of disorders, which we can intervene with. In contrast, you might have learned, I think you have learned about some genetic disorders where coagulation, clotting factors, the gene for them are faulty. And so we have bleeding disorders. So it's a balance, a delicate balance, and that's all I describe here in this writing. So, as a reminder, anticoagulants are used to prevent clots or thrombi in veins and arteries that are at risk for thrombosis. So there are a variety of conditions, and forgive me if I'm reiterating something you know, but I want to remind you, there are a variety of conditions that put us at risk for pathological thrombi formation. This includes heart disease, whether it be valvular disease, atrial fibrillation, or coronary artery disease, atherosclerosis, circulation problems, congenital heart defect in valves. A thromboembolism is a blood clot that interrupts blood flow. So thromboembolism. And this can cause an ischemic stroke, a heart attack, or myocardial infarction, or pulmonary embolism. AFib is another common risk factor for clot formation. This is an irregular heartbeat localized to the atrium. So we'll use the drugs I'm going to talk about in all these situations. DVTs are another thing that elevates your risk for blood clots, and this can often result in delivery of a thromboembolism to the lung. This is called pulmonary embolism, and we'll intervene pharmacologically in those things as well. And we'll talk about MI or myocardial infarct, but also anticoagulants are often given prophylactically after surgical or during surgical procedures, particularly joint replacement, where you beat the crap out of blood, perturb the blood, activating clotting cascades. You like that? Beat the crap out of blood? It's a classic Bockman. You'll love it. You'll see it on boards. Okay. This reiterates what Dr. Groh, I believe, talked about. This shows the vascular wall when it's damaged, revealing things like collagen and von Willebrand factor. The point here is that when that happens, platelets adhere, and then they're activated and they secrete. And a variety of things happen here. They secrete things that produce vasoconstriction, which of course limits blood loss. So this is some of the early steps. The other thing I want to bring to your attention is the activation and secretion. So you release things like adenosine diphosphate, ADP, thromboxane A2, and 5-HT, which is serotonin. And both thromboxane and serotonin themselves cause vasoconstriction. Important thing I want to point out, because we'll talk about aspirin later, is platelets express cyclooxygenase, platelet cyclooxygenase, which is blocked by aspirin. Blocking cyclooxygenase with aspirin prevents the release or synthesis of thromboxane A2. So ultimately, it's how aspirin works, by blocking thromboxane A2 production. Anyways, these mediators act in a paracrine fashion on other platelets, causing or beginning the so-called platelet aggregation phase. Y'all see that? Okay, cool. So you see a degranulation, release of things, aggregation, and you see the formation of the platelet plug. Others, I saw their slides, crazy, man. I feel so sorry for y'all, but I'm a simple guy, so I'm going to make it simple. All this stuff that others have showed you, intrinsic and extrinsic, and all them numbers before that, like 8, 7, 6, I don't care. Okay? Ultimately, you'll learn from others, the extrinsic and intrinsic pathway come together and ultimately activate factor 10. If you haven't figured it out, and I know y'all have because you're smarter than most, the A stands for it's been activated. Okay, so remember, these Roman numerals are just exciting names for serine proteases that are activated by the previous Roman numeral, which then cleaves something at the serine, activating it, and then the next one, and the next one, and the next one, okay? That's all it is. Sequential serine protease proteolysis. Okay, ultimately, the point I want to bring to your attention is when factor 10A is activated, factor 10A then activates prothrombin into thrombin. Thrombin is also called 2A. I bring this to your attention because antithrombin, which is a circulating anticoagulant, so it's part of our endogenous natural pathway that keeps blood fluid. I bring this to your attention and I draw it in red. I did that in paint. You like that? I stole the figure, but I added antithrombin. That was me. Okay. Antithrombin is a target of a major class of anticoagulants I'm about to talk about. All right? So it's important to understand what antithrombin does. All right? Antithrombin inhibits 10A and 2A and some others. And we're going to talk about targeting antithrombin in a minute. So ultimately, though, when thrombin is activated, or factor 2A, it converts fibrinogen into fibrin. And fibrin is the insoluble fiber that forms the clot, stabilizing and strengthening the plug. All right? And this I really meant to delete, but it's just to remind you that there are a variety of serine proteases that precede factor 10A. Others might make you responsible for it. But again, I want you just to know this part, 2A, antithrombin, and thrombin's activation of fibrinogen into the fibrin clot. This might be important, by the way. The pathologists tend to like this because a lot of the laboratory tests on blood coagulation factors are revealed in this figure. So it might be helpful for you. Okay, the four major classes of anticoagulant drugs are listed here. The indirect thrombin inhibitors, which I just introduced to you, the oral vitamin K antagonists, the oral direct factor 10A inhibitors, and the direct thrombin inhibitors. Let's first look at the indirect thrombin inhibitors. So they bind to antithrombin, which I showed you in red earlier, catalyzing its activity. So antithrombin naturally is inhibiting coagulation right now, presumably, unless we need to clot. Gesundheit. What the heparins do is catalyze antithrombin. In other words, speeds up its enzymatic activity, if you will. All right. So the heparins are the major class of indirect thrombin inhibitors. They catalyze antithrombin. There are three major types of heparins you need to know about. Unfractionated heparin, abbreviated UFH, also called high molecular weight heparins. You got your low molecular weight heparins, and you got a synthetic peptide called Henry Fonda or Jane Fonda Paranux. Y'all don't know who Jane or Henry Fonda are. What about Peter? He just died. He was cool, right? Easy Rider. You're all too young. All right. I'm too young for that. A little bit for it. Anyways. How does heparin work? Again, it's indirect acting by binding to antithrombin. Antithrombin, in turn, inhibits 10A, 2A, and 9A. So that's its, quote, mechanism of action. All right. Heparin is most often used in a hospital setting. It's primarily administered intravenously or continuously through IV, intravenous. Its rapid onset of action is important for its therapeutic use because you can give it to prevent and manage DVTs if it presents in the emergency department, pulmonary embolism, initial treatment preventing thrombosis in acute coronary syndrome, and during interventional procedures like angioplasty and bypass. So heparin's being administered either during an acute emergent situation like acute coronary syndrome, which puts you at risk for clots, those kinds of things. You'll get heparin on board in an inpatient setting, but they're used during interventional procedures too to prevent clots from forming, like balloon angioplasty and bypass, etc. I'll talk a minute about administering it subcutaneously because generally that's done in a different setting. Heparin has a short half-life, and it correlates specifically with dose, so it has odd pharmacokinetics. It's not metabolized by the liver or the kidney, so there's no issues of disease states affecting individual dosing. It doesn't cross the placenta, so it can be used during pregnancy. The major adverse effects are the following. Minor bleeding is very common, manifests as bleeding in the gums or a facial cavity. Other adverse effects, thankfully not as frequent, but still not rare, 1 in 20 people will experience major bleeding. This is very dangerous. Major bleeding means a GI bleed or an intracranial bleed. Not good. Hypersensitivity, osteoporosis, alopecia. The adverse effect that happens in about 1 to 4% of people, so I averaged it out to 2, is heparin-induced thrombocytopenia, HIT, defined as a 50% decrease in platelet count. If this happens, heparin must be discontinued immediately. I will give you an alternative to heparin in a minute if your patients experience thrombocytopenia in response to heparin. So this is really a limiting adverse effect of heparin. The low molecular weight heparins include Lovenox and congeners of it. Lovenox is very commonly used. It inhibits the factors that I already mentioned. The indications are similar to high molecular weight heparin, but it's more commonly used because its anticoagulant response or its efficacy is more predictable than the high molecular weight heparins. It's fast acting, and it's predictable bioavailability, and it's often given subcutaneously in an outpatient setting. So if an individual, for example, has been treated by you in an inpatient setting, right, they're AFib or DVTs or pulmonary embolisms, you've managed it, whatnot, they may very well be given Lovenox sub-Q, trained how to use it, sent home with it to administer it on a daily basis. So this happens fairly often. The low molecular weight heparins have a lower incidence of thrombocytopenia, but they're eliminated renally. So individuals with renal disease might need dosage adjustment. Let me remind you about whether we care about dosage adjustments and the relationship between the dose-response curve for beneficial effects versus adverse effects. When you're dealing with drugs that are used to prevent clotting, think about it. You want it to work because clotting is bad outcomes. But you don't want it to work overtime because bleeding is bad, right? So you get it? We're working with really sensitive limitations. So it's very important to understand individual factors that might affect outcomes. So renal disease is relevant in somebody using this. The synthetic peptide fondaparinux is also given subcutaneously and can be used in an outpatient setting. Its advantages include no heparin-induced thrombocytopenia. It has a long half-life, allowing for once daily dosing, which again is often beneficial in an outpatient setting. Laboratory monitoring is not required. However, unlike the heparins, there's no antidote to overdose. I'm going to introduce antidotes to you in a minute. Again, if somebody starts bleeding out, it's really helpful to have an antidote, right? So the no antidote to excessive anticoagulation is a limitation. Heparin's action or excessive bleeding can be reversed, thankfully, with a compound called protamine sulfate. Protamine sulfate, which directly binds to heparin, inactivating it. The dose of protamine is based on the amount of heparin used. Here's the arithmetic. Low molecular weight heparin reversal with protamine sulfate is not as complete, and again, it lacks for the synthetic peptide fondaparinux. I don't know how to pronounce it. Y'all ever went to those websites where it tells you how to pronounce drugs? Come on, you could spend hours on that. All right. Another very important class. So the heparins are very important, all right? Particularly in inpatient settings where coagulation, DVTs, pulmonary embolisms, etc., are challenging. Oral vitamin K antagonists are also widely used. They're slow acting, so they're not fast acting like heparin. So they're not used during emergent situations like the heparins often are, as I already discussed. They're slow acting and they're given orally. They're derivatives of coumarin. Of course, many of y'all from the great state of Wisconsin know the story of coumarin, of warfarin, right? Anybody? Anybody from Wisconsin? I won't tell the story then. But it has to do with cows bleeding out. Anyways, the chemist and the pharmacologist who discovered warfarin and made it, they named it warfarin because warfarin stands for Wisconsin Alumni Research Fund. Their alumni gave their scientists money. Remember that when I come knocking on your door. All right? All right. Anyways, these are called oral vitamin K antagonists because they block vitamin K-dependent synthesis of a variety of clotting factors. So a lot of the synthesis of these clotting factors depend on vitamin K. And warfarin blocks the vitamin K component of that synthesis. Perhaps you've learned this. I just want to bring this to your attention because it has clinical application. The clotting factors have various half-lives, from long, 60 hours, to very short, 8 hours. So warfarin works by blocking synthesis of these. This is relevant. So for example, somebody's on heparin in-house in the hospital setting to control clotting because they presented with pulmonary embolism, and then you put them on, you controlled it, now you send them home. You can't just stick them on warfarin in an outpatient setting. Why? Because these clotting factors, some of them are still around. You got to wait for warfarin's action to become complete. Make sense? So it takes 3 days, right, almost 60 hours before peak anticoagulant effect. So oftentimes, somebody will be discharged from the hospital on Lovenox, low molecular weight heparin, sub-Q, and warfarin simultaneously. And then after 3 days, they'll discontinue the Lovenox, and they'll stay on oral warfarin. So that's why the half-lives of these clotting factors are important. Warfarin's well absorbed orally, and that's an advantage in terms of outpatient treatment, metabolized by cytochrome P452C9, which you may or may not remember is extremely polymorphic variant. So it has single nucleotide differences amongst all of us that translates into some of us being fast CYP2C9 metabolizers versus slow. And this is very important because warfarin's primarily metabolized that way. So you know that that can affect warfarin's efficacy, right? And remember, we're talking about preventing someone's AFib from producing a clot and a stroke. Remember, the thing goes from there to there, and right? Or we don't want them to bleed out. So we really want to control blood levels. So any variation in warfarin's metabolism is relevant to how you individualize the dose. Let me repeat, warfarin's therapeutic index is very narrow, which is why its half-life is quite variable. Some of us are fast metabolizers, some of us are slow. I'll remind you now, there are genetic tests available for you if you use warfarin in your patients to test to whether or not they are a fast metabolizing phenotype or a slow metabolizing phenotype. This will inform your dosage. And you thought last year's lecture on drug metabolism was irrelevant. Here it is. Where am I? 2C9, blah, 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 warfarin oral. Okay. Warfarin for 50 years, maybe 70 years since World War II, has been the mainstay of anticoagulation therapy in an outpatient setting. It's been used for everything from venous thrombi, valvular disease, embolic disease, prosthetic heart valves, AFib, miscellaneous, anything that puts you at risk for clots. Warfarin has historically been used. Yeah, before I move on, perhaps you don't know, and it has to do with the variation in half-life due to variations in individual capacity to metabolize warfarin and the very narrow therapeutic index. A patient on warfarin generally has to go to a lab monthly to have blood drawn and blood levels measured. This is how concerned we are to control, clamp, if you will, regulate the blood levels of warfarin, because it's very difficult to give an individual a fixed dose and predict what blood level will result. Make sense? Because of CYP2C9 variability. And again, when we're talking about clots versus bleeding out, we really don't want a lot of movement. So, warfarin's challenging to use, but it works. And if you can get it right, it can be used in a cornucopia of clot risk factors. What are some of the adverse effects? Obviously, bleeding. Again, the major bleeding, intracranial and GI, as well as the minor bleeding, can't be used during pregnancy like heparin. I already told you about the adverse, well, okay, let me go here. Of course, you know, any drug that's metabolized by cytochrome P450, particularly one like warfarin with a narrow therapeutic index, has the potential for interacting with other drugs that may affect cytochrome P452C9, right? So again, all that basic stuff is now being applied. So let's go through this table. On the left, we have increased prothrombin time. On the right, we have decreased. I believe Dr. Groh or another pathologist talked about prothrombin time as a measure of warfarin's efficacy, right? How long does it take for blood to clot in a test tube, I believe, and he probably went into all that. But for my sake, just remember, increased prothrombin time makes you a so-called bleeder phenotype. Make sense? increased PTT. Y'all following that? Versus decreased prothrombin time, you're more of a clotter. All right, so let's look at the left. There's some pharmacokinetic. I don't have a clock, man. I'm at a loss. Does that work? Is that right?
Yeah.
Okay, we'll go with that. Okay, increased prothrombin time or putting you at risk for bleeding. Gesundheit. Include some of the following: pharmacokinetic. So you all recall cimetidine, right? Cimetidine blocks irreversibly to a variety of P450 isoforms, including 2C9. So you're blocking warfarin's breakdown, leading to accumulation of blood levels, prolongation of half-life. Remember all those rules? Here it is. So cimetidine and warfarin is pretty much a no-no. And this is important because people take cimetidine and won't tell you, because you get it over the counter at 7-Eleven to treat heartburn. There's also, I'll list a few of them, but also the antifungal drugs are notorious for blocking metabolism, increasing warfarin's PTT, or bleeding thing. So those are pharmacokinetic interactions. There's also pharmacodynamic interactions. For example, take a drug like aspirin, which inhibits platelets and puts you at risk for bleeding, in combination with warfarin might be an additive bleeding action. That's pharmacodynamic. You all able to distinguish a pharmacodynamic interaction from pharmacokinetic? It's a classic way of classifying these things. And the other oral anticoagulants, which I haven't talked about, although I can't imagine a physician putting someone on one of these oral anticoagulants, which I'm going to talk about in a minute, and warfarin. I'm pretty sure you better get a lawyer if you do that. Don't do that. And of course, hepatic disease. You all know that a drug metabolized in the liver in the setting of hepatic disease might require dosage lowering. So again, this is it's a good teaching example because warfarin's got a narrow therapeutic index. It's metabolized by an isoform that is polymorphic variant. So it has all the little principles that you can apply to other drugs. Warfarin's a good example. The opposite side, decreased prothrombin time. Drugs like barbiturates, and again, the only barbiturate of note anymore is phenobarbital. Phenobarbital, PHEN. That's used sometimes to manage seizure disorders, right? Seizure disorders. Phenobarbital is notorious for inducing the genes encoding for P450s. You remember P450 induction? So that's going to make you a fast metabolizer, meaning resulting in more of a coagulation risk or failure of warfarin's efficacy. Y'all connecting those dots? That's how I want you to think. So if somebody's taking phenobarbital, they're inducing P450s, making you a fast metabolizer of warfarin. All of a sudden your patient's forming clots. Clinically, this can be manifested as a decrease in prothrombin time. So that's a classic example. There are also pharmacodynamics. So vitamin K, remember warfarin blocks vitamin K dependent synthesis of clotting factors. Vitamin K, warfarin's a food drug interaction. Vitamin K is enriched in green leafy vegetables, for example, like kale or spinach. Yay. I'm a spinach. So the camp's usually in two, right? Some are kale people, some are spinach people. Huh? I'm going to Portugal, you're not. I already got a full day tour of wine country. I got a guy in Lisbon meeting me for a bicycle trip. Oh man, I'm going to be thinking about you guys. So, not to say you can't have a spinach salad on warfarin, but I suspect a nutritionist at the hospital, if your patient's on warfarin and, talk about daily consumption of green leafy vegetables, it does become relevant. So again, this antagonizes, if you will, warfarin's efficacy. Thus, you might again put your patient at risk for clotting. And again, here's some, quote, individual factors that you can look at. All right? So, be clear. Left, increased PTT. Right side, decreased. Pharmacokinetic, pharmacodynamic interactions. If I haven't repeated myself enough, there's a reason why, okay? All right. Heparin, of course, has protamine as a reversal agent. Warfarin, usually stopping the drug may be sufficient. Okay. Sometimes, if somebody's bleeding or you want to reverse warfarin's action, oral or parenteral vitamin K can be useful. Make sense? You're giving vitamin K. It's like eating spinach on drugs. But this effect is delayed. It's not immediate. If it's an emergent situation, acute, emergent, many societies like the Thoracic Surgery Society and others developed the chest guidelines. In an emergent situation, you are essentially replacing the patient by giving them all the vitamin K dependent factors that had been inhibited by warfarin. You're giving them factors 2, 7, 9, 10. Giving it back to them. Kind of analogous to hormone replacement therapy, but clotting factor replacement therapy. This is rapid reinstallation of an individual's ability to clot. So this is usually, and in general, these are called prothrombin complex concentrates. This is administered typically in an acute emergent situation to rapidly reverse warfarin's action. So you have 3 different approaches depending upon your need. Okay. If you haven't gotten the point, although warfarin was a beautifully cool breakthrough in clinical management of coagulation, risk factors, believe me, it changed medicine. And I also like this story because it's a classic example of observation of the natural world, natural products, development of a drug, changed medicine. That's pharmacology. It's got everything going for it. Also, it's a great teaching tool because the therapeutic index is narrow, which makes it clinically significant. And it's got drug-drug interactions based on metabolism. It's really cool. But, as if you haven't appreciated all that, warfarin's a pain in the butt to use. It requires monthly laboratory monitoring. The therapeutic window is narrow. So anyways, there was a real unmet need for development of equally efficacious anticoagulants that are easier to use. And here are the following. So these were developed in the last 15 years as a result of rational drug design, so it's really cool from a pharmacology perspective. These are also orally administered, so they can replace warfarin in that regard as an outpatient treatment of risk factors for coagulation. And remember the figure I showed you, these directly block 10A. That figure makes sense now, doesn't it? That's right, it does. Anyways, I rarely provide brand names, but I do here because these are currently marketed on TV, radio, internet, social media widely by the companies who make them because they still have patent protection over them. So your patients are very familiar with brand names. They'll go, I want Xarelto, I want Eliquis. So I provide these for you. So these are some of the players. Xarelto, Eliquis, I don't know. Endoxaban. Okay. Anyways, you can see they all end in ban. These are all orally administered direct 10A inhibitors. They're highly selective for 10A. So they're more selective than warfarin, right, which blocks a lot of factors. Dose titration, not necessary. So by and large, there's a couple of doses that are being marketed for y'all to use, and you probably pick the lowest dose, if I were you. See if your patient responds, and you don't have to worry about it. So there's minimal laboratory monitoring, so it's easier to use for a physician. Patients are more compliant, etc. I will tell you, this is a dynamic area. So I, review the literature, and there's lots of discussion by physician scientists and basic scientists about dosage adjustments of these. So the initial optimism with these drugs about, fixed dose, use it in everybody? Yeah, we're starting to sober up a little bit. We're starting to see individual factors, renal disease, whatever, that may require a little bit more hands-on dosage adjustment with these drugs, okay? But it's dynamic and changing, so it's difficult for me to teach, but this is what you're in for. But still, they're easier to use than warfarin by orders of magnitude. So the dose titration, there may be some necessary. You'll learn this with clinical experience. Every day is new paper about this, but still easier. Monitoring blood levels are minimal. They're oral like warfarin. They have rapid onset, unlike warfarin, but they do have a shorter half-life, which means patients might require more than daily dosing. And again, you may be surprised how compliance often affects therapeutic outcomes. So never forget to ask your patient, are you taking it twice a day as instructed? Oh, really? So maybe as simple as that. They're indicated for many reasons, just like warfarin, prevention of DVTs, for hip and knee replacement. They're also given prophylactically with people with non-valve disease, for stroke prophylaxis, etc. One fundamental difference between warfarin and these drugs is warfarin can be used in people with valve disease or with artificial valves. These drugs cannot be used in people with valve disease or artificial heart valves. So then if that's your patient, they have to stay on warfarin. So that's an important distinction. Okay, let's look at the direct thrombin inhibitors. They act by inhibiting thrombin. They don't interact with antithrombin like heparin. So they directly interact with thrombin. Bivalirudin is the major player, and this is important. You guys are probably too busy to follow, the current medical literature as it's unfolding on a daily basis, but I do. And in fact, physicians are reporting en masse throughout the country that heparin is failing for them in cardiac cath labs, emergency rooms, all sorts of places, and nobody really knows why. There's some discussion that the manufacturers in China are diluting it to save money, or, there's all sorts of explanations that nobody really knows. But physicians are reporting it nationwide. And I just read an article how hospitals are stocking up on bivalirudin to replace heparin if their patients aren't responding. So this is literally happening real time, you guys. Huh? Contemporary, baby. This is why I don't use textbooks. They're so last decade. So, to bring this home, bivalirudin and this one, administered IV for clot prevention in coronary angioplasty and bypass. So similar indications as heparin, if you recall. The reason why heparin is favored is it's cheaper, a lot cheaper. Bivalirudin is it's expensive. But it's now, hospitals are stocking up on it in case heparin fails. But importantly, in patients who demonstrate heparin-induced thrombocytopenia, HIT, bivalirudin is the alternate, okay? That was the original reason why I made this statement. But only in the last week have I learned about heparin failure and contamination, whatever. All right? So this is cool, bivalirudin, very contemporary. There is Pradaxa, which is an orally administered agent, and this is being used for many of the indications that warfarin and the other oral agents on the last slide are used, but its mechanism is to directly inhibit thrombin. And it's a big player in the oral world because there is a reversal treatment available in case your patient experiences excessive dose effect, Pradaxa. As described, the oral agents are used to prevent stroke and non-valvular AFib, systemic embolism prevention, etc. So similar indications as warfarin and direct factor 10A inhibitors, but its mechanism of action is different, and it has the advantage of having a reversal treatment available. I will say, these bad boys, the 10A inhibitors, there's a lot of effort right now being put into developing reversal agents for them too. Physicians are very cautious about using these drugs without having a reversal agent available, because bleeding is bad. Make sense? Not like, I don't know, side effects of headache. We can tolerate that. Bleeding is bad. So, my guess is Pradaxa is probably gaining ground amongst you all because there's a reversal treatment available. But seriously, by tomorrow there may be one available for the 10A inhibitors, okay? You all good with that? It's a very exciting time if you're in this business. Okay, let's make the comparison. Comparison of the direct thrombin like Pradaxa and the oral 10A inhibitors with warfarin. Similar antithrombotic efficacy, that's really good. Lower bleeding rates, good. Rapid therapeutic effect, better than warfarin. Minimal to no monitoring required, much fewer drug interactions. Not affected by diet. Usually dosage optimization not necessary, but as I mentioned, I qualified that. This is a very dynamic field where there are reports in the New England Journal of Medicine and other journals every day, JAMA, about this. So, although there are standardized dosage protocols, there's probably going to be some movement in that area, but again, much easier to work with than warfarin. Short half-lives, unfortunately, are a downside. If patients are non-compliant, you may lose the anticoagulant effect, and again, that's not good. Okay. I'm moving really fast. Y'all mad? Should I slow down? Keep going? All right. Whew. Moving fast because I got to go. All right. What can I tell you about Portugal? Anybody from Portugal? All right, I'm moving on. Let's change gears, kind of. So the drugs I talked about, heparin, the warfarins, the 10A, the thrombin inhibitors, prevent coagulation, etc. Now we're going to talk about so-called clot busters, where we dissolve the already formed fibrin clot. These have specific uses, and they're used by specially trained healthcare professionals. Not every schmo with a white coat can use these, all right, including me. I got a lot of white coats. I don't even wear them anymore. I like the way the pathologists come in with the lab coats, right? It's like some kind of power thing. You don't even know if I'm wearing underwear or not. Totally different approach. Don't think about it. All right. This figure's complicated. I don't want to make it complicated. Again, it's not a great figure. It's the best one I could find. I should have modified it with paint, but I didn't. I'm going to make it easy for you, because it is easy. I just want to direct you to the drug targets in this pathway, all right? I introduced to you right away that homeostasis, the equilibrium in the system we call blood, is delicate, where our body is at times controlling clotting, but also dissolving clotting. We have our endogenous, naturally produced enzymes that dissolve clots that are inappropriately formed. And this is a delicate balance, all right? One of those important proteins that are important in cleaning up or dissolving unwanted clots is a liver protein called plasminogen, shown here. It's inactive. Ultimately, it's activated by things like TPA, which is, again, endogenous or naturally produced. It stands for tissue plasminogen activator, right? Activates plasminogen, made in tissue. Real easy, all right? It activates, it's indicated by this plus sign, into plasmin. Plasmin then, shown here, dissolves the clot. That's all I really want you to know. Plasmin dissolves the clot, interferes with thrombin, dissolving the clot, all right? So TPA activates plasminogen into plasmin, which in turn degrades or lyses the clot, especially new clots. All right, let's talk about drugs that mimic this system. Guess what? The most common clot-busting drug used is TPA. We administer TPA to activate plasminogen, dissolve clot. So that's cool. Another drug is called urokinase, which does the same thing. The distinction here is these are direct activators. I say this because the other drug that can be used to dissolve clots is streptokinase, but it works through an intermediate. So it's often classified as an intermediate acting clot-busting drug. That's all I want you to know, all right? TPA, urokinase, directly activates plasminogen into plasmin. Streptokinase works through an intermediate. In a minute, I'm going to talk about people who have bleeding disorders, whether they be hemophiliacs or, as I believe somebody has introduced to you, those with genetic abnormalities in the genes that produce clotting factors, so-called clotting factor disorders, right? Von Willebrand's disease, other things. In those individuals, we can use drugs like aminocaproic acid to inhibit plasminogen. So here we're promoting clots. Does that make sense? On the left side, we're dissolving clots. On the right side, we're preventing plasminogen formation into plasmin to dissolve clots, thereby tipping the thing to being clotting. Make sense? We want someone to clot if they have a bleeding disorder. I'll get back to this. So I want you to know what the left side means and the right side means. Okay. The fibrinolytic agents, in other words, drugs that lyse fibrinolytic agents, streptokinase, urokinase, recombinant tissue plasminogen activators. They are administered intravenously and intraarterially, again, by specialized individuals who know how to use it. Because imagine the therapeutic window on these bad boys. You start inhibiting clot form or dissolving clots, you can really go too far. Plus, intraarterial administration is a skilled route of administration. Okay. When do we use them? Pulmonary embolism, or clots in the pulmonary vasculature. Very bad outcomes. Acute ischemic stroke. So this is a stroke caused by a clot in the cerebral vasculature, not a hemorrhagic stroke. These drugs, of course, are contraindicated in hemorrhagic strokes. These are ischemic strokes. And acute myocardial infarction, which is a blood clot in the coronary vasculature. The timing is very important. If somebody is experiencing signs and symptoms of ischemic stroke, there's a window of 3 or 4 hours where they need to get to a stroke center where there are healthcare professionals who could administer TPA or uro or streptokinase. And again, not every emergency room in this country have individuals that use this. And so this is why many hospitals, I believe UNMC and Creighton, both have stroke-trained individuals. Someone presenting with an MI, you have a bigger window, up to 6 hours, where these drugs can be used. So again, the idea is to dissolve the clot where we're having a stroke or where we're having a heart attack. And again, what we're doing is reperfusing the ischemic tissue, right? We're facilitating reperfusion. Does that make sense? Via clot busting, dissolving, lysing the clots. Also used in DVTs. Shall we take a break? I've got 4 more slides. Or should I just finish it in the next 10 minutes? Anybody want to take a break? One person, and I'm done. All right, let's move through here. All right. So, drugs to treat, prevent coagulation, drugs to lyse, blood clots. Now we're going to introduce to you for the few agents available to be given to individuals who are so-called bleeder phenotypes. Vitamin K can often be given, particularly in newborns who are not yet expressing the coagulation factors completely. Vitamin K is a fairly safe agent. It confers biological activity on prothrombin, the factors that depend on vitamin K, etc. Vitamin K is also, again, given during warfarin toxicity, as already described, etc. We can also give recombinant protein preparations or fresh frozen plasma to replace deficiencies in coagulation factors. So, for example, you've probably been exposed to individuals with factor 7, 9, 8 defects, or in hemophilia. And finally, the drug I showed you earlier, aminocaproic acid, but also tranexamic acid, inhibits activation of plasminogen. There. This can be given orally or intravenously, using hemophilia, bleeding from fibrinolytic therapy, and rebleeding prophylaxis from intracranial aneurysm. So these are a variety of agents: vitamin K, protein preparations, or just plasma, or these drugs to be given on a variety of phenotypes that are prone to bleeding. So here we're promoting coagulation rather than inhibiting coagulation. Okay, we all know and love aspirin. Aspirin is typically given orally, right? Over the counter. Aspirin has a fairly unique mechanism of action that distinguishes it from the other non-steroidal anti-inflammatory drugs like ibuprofen. They both block cyclooxygenase in the platelet. Remember, cyclooxygenase in the platelet is the enzyme responsible for the synthesis of thromboxane A2, which in turn acts as a paracrine hormone, inducing platelet aggregation and plug formation. So by inhibiting it, it's an antiplatelet drug. So you may ask the question, why can't we take ibuprofen to inhibit platelets? And the difference is simply this. Aspirin covalently binds to cyclooxygenase in platelets, causing an acetylation reaction. So it adds an acetate group on it permanently. The other non-steroidal anti-inflammatories block cyclooxygenase, but it's reversible and transient. So it's aspirin's permanent action that gives it special properties as a platelet inhibitor. Make sense? And essentially, by taking out platelet cyclooxygenase, you kill the platelet. It requires new platelets to be made. So, the permanent inhibition of thromboxane A2 inhibits platelet aggregation and prolongs bleeding time. This is the basis for so-called low-dose therapy, or as some people say, baby aspirin, which is stupid. You don't give babies aspirin, right? Okay. I prefer low-dose aspirin. Y'all remember dose response curves, right? 1 tequila shot versus 10, completely different outcome, right? Low-dose aspirin, high dose used to block inflammation. Low dose used to inhibit platelets. High dose will also inhibit platelets, yes, you'll become a bleeder. Low dose doesn't do crap for inflammation. Huh? Dose response curves. You all know that most guidelines, I better take this back. It's controversial. Every day somebody makes a different argument based on a data set. If you want to parse through it, feel free. You'll spend the rest of your lifetime coming up with whether or not you want to suggest to your patients they take low dose for prevention of myocardial events or stroke or not. Currently, I believe most guidelines say there's no reason to take low-dose aspirin as a primary prevention agent, meaning to and it prevent the first infarct or first stroke. Is that clear? However, most guidelines support the use of aspirin, daily, low dose, as a secondary preventative agent, meaning in those individuals who have had an ischemic stroke or have had a myocardial infarction, then aspirin is advised on a daily basis. Does that make sense? Please distinguish primary inhibition from secondary inhibition. And again, this is guideline driven that is changing almost daily. Okay, so-called super aspirin, ticlopidine, clopidogrel, etc. These drugs block the ADP receptor on platelets. So again, if you go back to that second slide, I showed how when the platelet's activated, it releases adenosine diphosphate or ADP, which in turn acts on other platelets, promoting aggregation. These drugs block that receptor, preventing ADP from promoting aggregation. These are so-called super aspirin because at least the early evidence suggests they inhibit platelets from aggregating better than aspirin. I don't know if that's true anymore, to be honest with you. But again, these are often used in individuals who are at risk for a secondary event. And they're often combined with low-dose aspirin. So for example, somebody who's had an ischemic stroke, somebody who's had a myocardial infarction, somebody who has acute coronary syndrome that may progress into something unstable, might take a low-dose aspirin and ticlopidine at the same time. Orally available, easy to use. So these are given to prevent thrombosis when placing a coronary stent and afterwards to prevent secondary MIs or stroke. So-called super aspirin, but they're really platelet ADP receptor antagonists. Now, these are very specialized drugs that I won't spend too much time on, but if you go back to that second slide again, you'll see the glycoprotein 2B3A receptor. And there the receptor is on platelets that bind fibrinogen. And remember, fibrinogen is the precursor to fibrin, that clot. So these things prevent that spidery tendril fibrin to form. So they're, unlike the antiplatelet drugs I just talked about, these are essentially, they block fibrin production. So they're kind of cool at the mechanistic level. So they not only inhibit platelet aggregation, but also fibrin formation, and they are, again, specially used drugs. They're monoclonal antibodies or complex proteins derived from rattlesnake venom. They're used, again, in a critical care unit or a cath lab or something like that, where continuous infusion during angioplasty to prevent aggregation and clots, during an unstable coronary syndrome, and also in conjunction with heparin and aspirin to reduce restenosis. Oftentimes after angioplasty, you unclog the plumbing, if you will, right? You all know angioplasty? But what happens is you remove all those endothelial cells, and that promotes restenosis, which is smooth muscle cell growth into the lumen of the artery, causing a clog, if you will. Right? These drugs have been shown to prevent that sort of hypertrophy and hyperplasia of smooth muscle cells, which is what we call restenosis. So that's kind of cool. All right. General contraindications of anticoagulant drugs, clot-busting drugs or fibrinolytics, and antiplatelets. Hemorrhagic stroke. That's something for when an aneurysm, for example, ruptures and we bleed out. This is fundamentally different from an ischemic stroke. You don't want to give these drugs if somebody's blew an aneurysm. Make sense? Somebody with a bleeding ulcer. I know, right? It's so obvious, but I had to say it. You would be surprised. Another thing that people don't realize is somebody with an active ulcer that's unstable and bleeding, these drugs may push it from being unstable to a bleeding ulcer, and certainly contraindicated in a bleeding ulcer. Very dangerous. Recent surgery can oftentimes be a contraindication when given these drugs. Anybody with a brain injury may be at risk for bleeding when given anticoagulants and ulcers as mentioned. Oh my God. Wow. Did I go too fast? I don't want to go too fast. Y'all got any questions? Don't tell the bosses that I did that in an hour and 10 minutes and cut me off next year. And then I'll really have to go fast. This is a really interesting area because it's changing daily in terms of developing new drugs. Definitely made your life easier. So I find it very interesting. Yes, sir.
Are there specific indications when you'd want to use a direct thrombin inhibitor versus a 10A inhibitor?
I think it's a dealer's choice. To be honest with you, I think they show equal efficacy, whether one works through 10A versus thrombin. I think Pradaxa, is that the thrombin inhibitor? I think it's preferred right now just because physicians know there is a commercially available reversible agent. But I believe there might be reversible agents on the market now for the 10A inhibitors or really close to coming to market. They're in like phase 3 trials or whatever. So all those drugs are going to be in your toolbox very soon. And that's changing practice for sure. All right, good job, y'all. See you around the neighborhood in about 10 days. Thanks for coming, by the way. All right.